Good morning, everyone. This is Karen Bett from the Global Partnership for Sustainable Development Data. I work as a policy officer, and it's good to have you all here with us. At the moment, we have 42 attendees joining us. I think the number is growing, actually 43 now. So without further ado, I'd like to kick off this webinar. As mentioned, thank you very much for making time to join us in this webinar. This is Joining Up Health Data in Kenya, contributing to universal health coverage. This is a webinar to mark the end of our project, and I thank you all again for joining us, and particularly our speakers and presenters, and for the Ministry of Health who are taking time to speak to us today, and also you as our participants to join us, especially during this difficult period in Kenya and the world over because of the COVID pandemic. As I mentioned, this webinar is one of the last activities that will be undertaken as part of the Joining Up Health Data in Kenya project led by the Ministry of Health with support from the Global Partnership and PEPFAR. Although, and I'll just give some quick remarks before I pass over to my panel. As I mentioned, this has been a one-year project, but it feels like it has been a really long journey. Over the course of the year, and we'll hear from Solomon Simba, we've worked closely with Dr. Sitiene, who is also with us from the Ministry of Health, to support the finalization and implementation of the Kenya Health Interoperability Framework and Roadmap. We feel that this document is one of the final pieces of e-health policy puzzle in Kenya, and it helps to lay the foundation for how the ability to join up data across the health system in Kenya can be further strengthened and rolled out. At the same time, our colleague from Hoji Limited, Gitahi, will also walk us through the support he's been providing the ministry, NASCOP, and the National AIDS Control Council to find ways of connecting multiple data sets that feed into key data dashboards used by policymakers in these institutions in HIV and AIDS. We feel that this webinar is an opportunity for us to hear from representatives, but also from government and the Ministry of Health, NACC, Hoji, and of course my colleague Simba, to learn about the contributions that have been made by this project to strengthen health systems in Kenya. And I know most of us have also joined to learn more about how they can work with the Ministry of Health in strengthening health systems in Kenya and thinking about next steps for health data interoperability in the country. I'll just take you through the run of show very quickly, what we've lined up for 1.5 hours. Of course, after this, I'll welcome Dr. Sitiene to give some opening remarks, and then I'll pass the baton to Solomon Simba to take us through the interoperability framework, and then I'll invite Gitahi. Next, I'll invite again Dr. Sitiene and George Onyango from National AIDS Control Council to just give the experiences and thinking on strengthening health data in the country. We'll then move to Q&A. Where we'll take some questions for about 20 minutes, and then we wrap up the webinar. Just for your information, we are recording this webinar, and this will be available after this. And also, if you have any questions, if you have any comments, we have two options to use. You can either use the Zoom chat option, or you can use the Q&A button at the bottom strip of the Zoom window. Last but not least, we'll launch a small poll at the end of this webinar just to know how well we did and to help us improve future webinars. So far, we have 51 attendees. I think they're coming in strong. So I'd like to invite Dr. Sitiene to give his opening remarks. Over to you, Dr.
Thank you, Karen. I don't know whether you want me to give my opening remarks only and then give a presentation later, or you want me to do both?
Well, whichever way works for you, Dr. I think we'll go with your advice.
Okay, then I will make my opening remarks and then quickly make my presentation so that at least we can try to catch up on time, if that is okay with you.
Yeah, that's fine.
Okay, I hope people can see me. I may be in a fairly dark place. I'm told that this continent that we are in is a little bit dark, but it's becoming lighter as time goes by. So allow me to thank the global partnerships and other partners who are in the webinar this morning for the support that we've gotten to the Ministry of Health to make sure that we are able to join the health data in Kenya and not only contribute to the universal health coverage, but use data for betterment of Kenyans, particularly in decision making. I can see quite a number of people who have joined in, and there have been several things which have been happening in Kenya. And for us, it is a great and exciting moment. It is our hope that even as global partnership winds up this particular project, that this is the beginning of everything and the end of nothing, in the sense that we shall be able to engage much more beyond what we've done together in the last 1 year. It has been fairly busy and very hectic, and I'm glad that we've, at least for once, we've achieved quite a major milestone. And one of the things that we'll be presenting today is the interoperability framework for Kenya. And with that, kindly allow me to share my screen so that I can be able to make my presentation. Disable participant screen sharing. Allow me to share the screen.
Okay, just bear with me one moment. I will.
Okay. So thank you very much for everybody as being allowed to share the screen. I can see quite a number of partners who are with us. I can quickly recognize CDC. I think I can see Davis Kimanga somewhere. I can see people from the ministry, people from beyond, people from different partners who are working with the Ministry of Health. I want to really welcome you to this important meeting and to thank you for creating time to be part of this discussion, so that together we can be able to build a resilient country called Kenya. So I'm waiting to be allowed to share the screen so that I can make my presentation at this stage.
You'll just bear with me, Dr. Rabit, as I sort the technology. Maybe what we can do is I can allow maybe Solomon to just introduce himself, Gitai introduce himself, and Davis, and then I sort this out.
Thank you, Karen.
Solomon,
thank you, Dr. Yes. Thank you, Karen and Dr. Sinai, for the introduction. My name is Solomon Simba, the Interoperability consultant for this assignment. And I'd like to say thank you for all those who have joined us today for this important webinar, as we prepare to quickly just give you an overflow and the walkthrough of what we have been able to achieve and documented, and what we intend to have in place, so that we see how the Kenya Health Interoperability framework can be that much needed guidance for us to be able to harmonize our space. Thank you, as I wait forward to take you through the framework later.
Thank you very much, Dr. Sitenay. Really good to see you, and welcome to everybody. My name is Davis Adieno. I'm the Director of Programs at the Global Partnership for Sustainable Development Data. Just to add, it's been an absolute pleasure to work with Dr. Sitenay and his team. And of course, not an easy journey, but we truly appreciate all the support we've gotten, and everybody who has really contributed in one way or the other to the development of the interoperability framework. Of course, we'll give the official thanks at some point to everybody else and all the other agencies that have been involved. But just to mention that when we started the journey back in 2018, this was in Dubai, when the Global Partnership and the UN Statistics Division, together with a number of global partners, we were launching the interoperability guidelines that had been developed over that particular year during the World Data Forum in Dubai. And I recall representatives from Kenya, Philip Thigo, and many others approaching us and saying, we see value in the interoperability guidelines, and if there's an opportunity really to work with the partnership and the Ministry of Health, and of course other stakeholders, the Office of the Deputy President, and many others, to try and put this into practice in Kenya. So that request formally came from the government of Kenya. And of course, we spent quite a bit of time, towards the end of 2018 and of course the beginning of 2019, looking at the modalities of how this would happen. So lots of you were consulted, and of course, the PEFA team really stepped up and they were very supportive. Of course, the measure evaluation team, and creating all those connections with all these different partners has been a really valuable experience for all of us. And of course, this is such a great milestone for us, because it was building, the way we approach this work is to basically provide complementary support to what is existing. And of course, the ministry has, over the last many years, has done a lot of work in this particular area. So this was, complementary work, to complement what Dr. Sitonei and many others have been working on in the area of interoperability. And of course, it meant that aligning whatever it is that we are developing to what was existing makes these guidelines, the framework itself, not only relevant, but quite useful to many stakeholders across the country. And we hope that, even across the region, many other countries will learn from this experience, as we often like to put it selfishly, Kenya has to lead and many others have to learn from it. So I will hand over to Dr. Sitonei. Hopefully the technology has been sorted out, and we look forward to very fruitful engagements with all of you. Thank you.
Okay, Davis, I don't know whether I've been allowed to share now. Nope, not that one. Oops. Are you able to see my screen?
We could, yes. Now you'll just need to put it on full screen and then we're good to go.
Yeah, I'm also challenged here technologically, and this is a period when we have learned that what is important during such times is use of technology. I think for once it has become very pertinent. Can you able to see my slide now?
Yes, all good to go now. Thanks.
Okay, thank you very much. And thank you, Global Partnerships, once more for allowing us to have this webinar this morning. I'm here to give an overview of how we are intending or how we are joining up health data in Kenya and contributing to the universal health coverage. I will take us through a few areas, including the history until we reach the conclusion. I think we are all cognizant of the fact that technologies have changed since 1999 in a robust manner. And these technologies, which have been coming up every other day, are changing every other moment. 1 year after the 1999, we had 50 internet service providers in Kenya, and 2 of them were telephony, those of you who are good in history. These innovations around internet and the use of IT are revolutionizing, by all means, how health systems are supposed to or should evolve to meet the demands of the health of the health sector. The facility-based digital health solutions in Kenya includes a broad range of ICT technologies, and they range from depending on who is the user and who is the innovator, ranging from hospital management information systems, electronic patient records, laboratory and pharmacy information systems, data reporting systems, supply chain systems, mobile data collection systems, operation systems, which include payment, insurance, and we'll come back to that slightly later. And all these have been deployed in our health facilities in different levels by different partners, and they are being used in different ways. I'm trying to advance and the slide is not moving. Yes, so in Kenya, like many other countries, people define health information in different ways. For example, for managers who work in the health facilities, it may mean aggregation of data. For nurses and doctors, it means data related to the patients and specifically on EMR. And I know in this webinar, there are a number of people who are involved in rolling out of EMR. We will talk about EHR again a little bit later. For the lab people, it may mean data related to samples and test results. Although HIS in reality is a broad term which encompasses more than the thinking that is currently there. It brings together data from different sources, whether it is routine and non-routine data, and enable decision makers to be able to make decisions and answer specific questions that affect particular aspects of the areas of operations. In Kenya, we are using the health system taxonomy that has been developed by the World Health Organization. This slide is a little bit populated, but you don't need to cram it. At this stage, you may not even need to see everything. But I think the most critical thing about the health taxonomy, the health system taxonomy, is the fact that digital health systems is defined as any electronic data system, tool, or intervention used within a healthcare facility for a range of purposes, as highlighted by the WHO standard classification team. And this is lifted from WHO health system taxonomy. We are all aware that we've moved from different positions when it comes to the collection of data. You can see previously people have been using the quilt and the ink. We've seen this type of equipment. I hope you are able to see this in this webinar. The typewriter that has been used for long. We have also had opportunities to see in our health facilities where the health records department requires extra space because of the number of records that are churned out in the health facilities. But we want to move to this smart system, which is on my lower right slide, where we are able to use devices that are digitally enabled. There have been significant efforts which have been made by several players, particularly to automate data generation and reporting purposes in Kenya, mainly because the system that has been there, which is paper-based, has its own challenges, which could be overcome by generation. Specifically, partners in the field who have been collecting data that is related to health have been frustrated by the existing system to an extent that they have come up with multiple systems which have limited capacity to exchange health information, as we'll be able to see slightly later again. And for the first time, good people, we've had very strong political commitment towards strengthening M&E and specifically to collect health-related data in Kenya. And that commitment is actually, as you can see in that slide, brought about by His Excellency, the President of the Republic of Kenya, when he launched the Big Four agenda, which currently is what has set the pace for the evolution of universal health coverage in Kenya. As you all know, there are 4 key pillars that His Excellency would like to leave as a legacy. And one of them is affordable healthcare services for all. And that is where we are hinged. And particularly when it comes to 100% universal health coverage, you can see that access is heavily hinged on digitization of the health. And this is number 8 in the critical drivers that are used in the universal health coverage. So how we proceed in terms of digitizing health, whether it is supply chain, telemedicine, patient care, will determine whether we shall be able to meet the aspirations of the universal health coverage, and also for the president to have a legacy. So for the first time again, we do have a very solid policy environment for digital health in Kenya. The Kenyan Constitution recognizes the right to information. The Vision 2030 has identified information as important part in development. We do have the Health Act 2017, which has made it mandatory that collected health data has to be reported. And if you don't report, then there are consequences. And to actualize some of these things, the government also enacted the Data Protection Act 2019 that looks specifically at data security and data storage. I think the part of storage is very critical, and a lot of the existing systems that are in the field do not meet the requirements of this Data Protection Act, particularly on storage. Again, in 2008, you may recall that under the medium-term expenditure framework 1, the government is on its way towards actualizing e-government to an extent that all government services should be as much as and as far as possible be provided through this platform. And I think some of us have interacted with these platforms, including the e-citizen and others which are already operational. There is a national ICT policy promoting use of ICT in the public service. And this is actually being actualized through the medium-term expenditure framework 2 and 3, where the government is putting up the data centers that we are all aware of, one of which is at the Konza City. There are additional 58 data centers that are going to be distributed throughout the country in relation to making sure that Data Protection Act is actualized and the government services are provided through the e-government. We also do have the policy environment within the Ministry of Health, the National E-Health Policy and Strategy, the e-health strategy, e-health certification framework, and now today we are discussing the interoperability framework that will be highlighted slightly later. And to make sure that the government is serious about what it has committed to undertake, the Ministry of ICT has been provided with finances to link all public facilities to the National Fiber Optic Project that is called NOFB, which stands for National Optic Fiber Backbone Infrastructure. As we speak, we have had 63 facilities which have been linked, and in this initial phase, the government in this financial year, which is coming to an end, I think today, it was supposed to link up 121 facilities which benefited from MES project. 63 have been linked. There were 38 which are ongoing, and more are having the land assessment going on. So the Ministry of ICT is not just to link them with the national fiber, but also to make sure that the land is operational. In addition to that, the Ministry of Public Works has been enabled or told to make sure that the road network is working and that these facilities can be reachable during the rainy or whichever type of weather. In addition to that, the Ministry of Energy has been given finances to link all the public health facilities to the national grid on power and to make sure that those facilities are also wired. This is a very serious commitment, ladies and gentlemen, that began in the current financial year and will go until all these aspirations have been met. Currently, the Ministry of Health is consolidating data that is stored in multiple sites, and we are all aware that this data that is stored in multiple sites need to be consolidated so that the government can actualize the use of this data for decision making. Most of these data storage sites are now supported by partners, and in the long run, that may not be very sustainable. And to actualize that, the government has moved in the current financial year that is ending today to ensure that it is procuring necessary equipment to facilitate development of an end-to-end digital solution, and also to make sure that we are able to have a data center that can be state of the art to put all data that is health related in one repository and to have a mirror in Konza City, as it is the government's desire. In 2018, there was a survey on ICT that was conducted in Kenya, and some of the partners who participated in this survey are represented in this webinar, where it was found that about 33% of the surveyed facilities, and these were more than 5,000, had some form of a functional digital health solution. Those of you who know Kenya, I think Taita Taveta had the highest digital health solutions coverage at 60%, amazingly, and Samburu had the lowest at 10%. This data is already in the public domain. In the survey, it was also found that there were some 10 digital health solutions that are widely used in Kenya. The top 10 are the ones that have been highlighted here, which was led by Linda Mama and followed by IQ Care and Kenya EMR. I think these mainly are within the HIV setup. We also had inactive top 10 ICT innovations that were not being in use. We also have digital solutions that are basically used in the HIV department, which I think some of us who are seated here today are fully aware about these ones. IQ Care, Kenya EMR. I know right now the HIV world in Kenya is moving to the Kenya EMR. And we also had some facilities which only had one system. But what shocked us most was the fact that there was one facility which had 12 different health solutions, digital health solutions that were not in any way relating to each other. And that was a very big shocker to us. Clearly, when you have 12 facilities, 12 systems in a facility which do not talk to each other, there is definitely a problem. And this is what we are talking about here, interoperability. Can they be able to operate? For us at the Ministry of Health, we would like to come up with a solution that is robust, sustainable, and that can follow best global practices, supporting the current and future needs of the ministry and the country. That is patient-centric, user-friendly, scalable, affordable, and of course, will be developed in consultation with the users, should be modular in nature so that it can be deployed where it's needed, interoperable, and developed in line with the 10 principles of digital solutions. It should incorporate all these clinical decision support systems, ICD-10 and 11 interface, all this, but specifically address specific concerns about e-health issues like privacy, security, patient recognition. It should also be able to provide a patient portal, enable up and down referrals within the care system, and operationalize telemedicine. In other words, it should be a solution that is an end-to-end solution within the health facility with interoperability standards that can enable all these standards to come together that you are aware of, so that we are able to have a system that can provide the required data for the whole country and for the government to make decisions. This is the national architecture that is currently being proposed, and this is the current architecture that we are developing at the moment. But notice that at the middle here is there we have the data orchestration and standards. This is the interoperability platform where we will link all health-related data from the ministry, from other departments of the ministry, like the Ministry of Interior. As you may be aware, the Huduma number is going to be rolled out very soon, and therefore this system should be able to be linked to the Ministry of Interior for purposes of unique identification of the clients. It should also include things to do with integrating the human resource information system, which is outside the ministry at the moment. It should also capture data from health facilities, supply chain, and have the capacity to provide early warning systems through early warning center. It should cover the whole CAF levels, the Kenya Essential Package of Health, from level 1 to level 6. It should also be able to link up outside into the private healthcare providers, whether they are private hospitals, faith-based, the financial systems, so that if somebody wants to pay for a particular service, they can be able to pay either through mobile payments or money transfer or whichever mechanism. The private insurance, private pharmacies and pharmacies which are in existence, all these should be linked. No wonder our meeting today in this webinar is so important, because you can see how vast the system is going to be, how many systems needs to be linked together to the data center that we are talking about, and to be able to provide those required services to anybody who is going to be allowed to plug into the system. This will also include, sorry to jump, this will also include things to do with the linkages to the DHIS. At the moment, the DHIS is collecting service statistics. The solution that we are looking at will be able to collect patient level data. And that is why it is becoming even much more important that interoperability framework is not only launched but adopted by everybody, and that we should all be working towards making sure that the solutions that are out there are interoperable, so that we can actualize telemedicine. The system that we are talking about will be a hybrid solution that will include the microservices. I think those who are experts in this field are better informed about this than me. It will have so many benefits to the patients, to the physicians, to the government. I don't want to go through the details of that, but we do anticipate that even as we look forward, we are going to face some challenges, but we are not saying that we shall not be able to be prepared to overcome them. We know we will, particularly if we work together as a sector towards moving everything in one direction, so that any solution that is out there should not tie anybody to any particular solution system, but should be able to provide things that can be able to be used in the country. We will overcome these challenges that include connectivity with time. We have to make sure that funds are available, and I want to announce that the government is so committed, as has been demonstrated in the current financial year, and looking forward in the medium-term expenditure framework that the government has come up with, that we are going to have resources out there to actualize the collection of digital data. In conclusion, therefore, I would say that Kenya is currently implementing standalone electronic reporting systems, as has been reported. There are so many out there. These systems are disparate and should be linked to create a robust end-to-end facility-wide electronic system. And the country has taken steps towards integrating existing digital health platforms through many steps, including what we are doing today. Thank you very much, and God bless you for listening to me. Back to you, moderator. Thank you.
Thank you so much, Dr. Sitiene, for that presentation. I think that has been really helpful in sort of setting the tone for what's coming up. And I know the questions have started to flow in, so we'll move pretty fast, and I'll pass this over to Simba to make the presentation on the framework, so that people get a flavor of what's included in the framework. And then I'll invite Kitahi to take us through the technology aspect that he's been supporting. So over to you, Simba.
Thank you, Karen, for the introduction. Thank you, Dr. Setne, for that detailed introduction as well. Because of interest of time, I'll just try as much as possible to take the audience through the look and feel of the interoperability framework, so that when you get the opportunity to see it, you can quickly be able to remember some of the things that we'll be talking about today. So the cover page looks like that, right? So the Kenya Health Information System Interoperability Framework, it's through funding support from PEFA, and also working closely with other implementing partners in country with the Health IT USAID funded project, which has been implemented from the University of Nairobi. The other side is just a disclaimer, which is normally something that we put across some of these kind of assignments, right? So the scope of and the structure of the Kenya Health Information System Interoperability Framework document looks at 4 chapters. The first chapter gives you an overview of the Kenya Health Information System Interoperability Framework, which includes issues like the objective, the scope, and the interoperability principles. Chapter 2 gives you that management of the Kenya Health Information System Framework, including the terms of reference for the governance bodies, membership criteria for some of those technical working groups, change management issues, looking at the compliance part of things, which is also includes in terms of compliance in terms of policy and governance with other institutions. Chapter 3 of it looks at the technical side of things, which is the interoperability architectural technical specifications, which have been selected as one of those priority areas that the framework deemed fit that they need to be in place within the sector for the interoperability components to flourish. And lastly, on the document, it talks about the certification process and the procedures that the framework tries to guide and recommend that needs to be in place to ensure that as interoperability has been put in place in the country within the HIS ecosystem, there's that procedure and guiding principles. So chapter 1, which is an overview of the Kenya Health Information System Interoperability Framework and its interoperability principles. Based on the interoperability framework's approach, it's important this time that I said that we decided to come up with or even to define interoperability from this perspective. That ability of 2 or more information systems or components to exchange information based on standards and to use the information that has been exchanged, right? So interoperability enables different health information systems to work together in across organizational boundaries to advance the health status of an individual, which is a critical agenda, and the communities and the effective delivery of healthcare to them, right? So some of the objectives that we tend to put across within the interoperability framework is to guide the national government and county level as well in terms of the approach towards the implementation of the HIS systems with information sharing capability. Also help to create a sharing or a shared understanding of interoperability in the Kenya e-health ecosystem. And some of the specific objectives that be important for me to mention here, and the document covers them in detail, is to promote the use of interoperability concepts and standards in harmonizing health information exchange in terms of technical and architectural activities within the Kenya e-health ecosystem. Also to introduce appropriate governance mechanisms, right? And organizational practices in support of interoperability, which is very important, so that you have that government and policy goodwill in the entire process. And also provide guidance on monitoring and ensuring that we monitor the interoperability maturity as we move along the journey of interoperability in this country, right? So some of the underlying principles that the framework looks at and our fundamental behavioral aspects to drive interoperability actions, we look at and they align with the principle of digital development, and we have tried to categorize in three stages, which are core interoperability principles related to generic user needs and expectations, and foundational principles for cooperation among public administration. To highlight a few, for us within the Kenya Health Information System Interoperability Framework, we look at transparency and usability as as a critical component, right? So ensuring availability of application programming interface, which is necessary for us and even for health system and subsystems within the ecosystem, have to respond to data needs of domain-specific internal processes, and also trying to build that environment where policymakers are able to obtain cross-domain insights for multiple HIS subsystems that exercise the element of interoperability. So securing protection of personal data is critical by ensuring that we respect the applicable legal framework on the health information sharing and confidentiality. This will be required that the applications that are within this space utilize and adhere to set standards based on technical safeguards, including encryption of databases and files and stuff like that, right? So chapter 2 looks at the Kenya Health Information System interoperability governance, management and compliance. I've been able to just pick a few highlights on that. So the framework looks and takes into details in terms of leadership and governance, which is critical. And it puts Minister of Health to set out guiding principles for digital health, e-health, health information system development, and implementation through coordination of the stakeholders coordination mechanism. So coordination and collaboration is a critical element for ensuring that the interoperability journey is achieved in this country. The Minister of Health shall also ensure that existing stakeholder coordination mechanisms, such as the national HIS interagency coordination committees or the health sector working groups, which are across all levels at national and county level, progressively include representatives from key HIS subsystems owners and relevant partners who support Minister of Health to strengthen its leadership and governance structures going forward, right? Compliance with the Kenya Health Information System interoperability framework is one of those things that the framework puts it in the core of the matter, and is one of those mandatory elements whereby that ensure that all health information system owners, for ensuring that they conform to some standardized way of health information exchange between HIS subsystems, and among interoperating health information systems. Compliance means that all HIS system owners are required to use those technical specifications which have been matured, which are common services, plus guidelines that are already in place, and shared health digital infrastructure to ensure that they conform to that dynamics and that environment, right, which has been approved within the sector for information sharing and information exchange. Chapter 3 looks at the technical part of things, which is interoperability architecture, technical specification. And the architecture which we are trying to adopt and even to work with is the Open Health Information Exchange, Open HIE framework. This means that for the Kenya Health Information System to be interoperable, it should be designed in accordance with the proposed model and with certain interoperability and reusability requirements in mind, right? So for this model, we promote reusability as a driver for interoperability, right? The basic components of the conceptual model are aligned to the Open HIE components layer. Interoperability service layer is one of them. We have highlighted some of the point of services through which we have mapped some of the existing in-country plans and the implementation of common services which are relevant to digital health solutions in the country. So this diagram gives you just a quick overview how we've been able to organize our digital health space. And we have the common services, business services, advanced analytics, and business intelligence and support services, which are interlinking with the interoperability layer. And interoperability layer service the point of care system of systems. So all this, again, interacts in a secure environment, which safeguards will be put in place and ensure that there's safety in terms of access and safety in terms of how information is shared across board. So I'll just touch on some of the common services that the interoperability framework has put as priority going forward. And is one of them is the terminology service. For us, the terminology service will look at to serve as a central authority to uniquely identify the clinical activities that occur within the care delivery process by maintaining a terminology set of mapped to international standards such as the international classification of disease, so that when we look at some of the patient forward systems, like EMRs or EHRs, we have that standardized nomenclature in terms of how we reference some of these things. We're looking at also coming up with a technical part of the standards, which is SS7 or even Firefast Healthcare interoperability resources to ensure that our systems share the same resources when it comes to information exchange. The other one that we'll be looking forward to advance will be the interoperability layer. That will be the core of the HIE architecture, interoperability layer, and a middleware component that will be designed to receive and coordinate transactions in the exchange process. The role will be to provide the linkage to point of service systems and offer that abstract and interface between them and the other component within the information exchange environment. Lastly, we'll be looking at client registry. And for the registry, we're looking at providing a unique patient identifier for each client. And this is something which is ongoing through other partners supporting the Ministry of Health to include the functionality of Enterprise Master Patient Index as a service that matches records from different sources referring to a single healthcare client. Chapter 4 looks at the HIA certification and procedures that the framework tries to put in place, or even recommends that they will be important to have in place. And the interoperability certification looks at leveraging the Kenya Health Information System Certification Framework to ensure that systems are certified and conform to the Kenya e-health interoperability standards. And those who are within that space are guided and work towards the same, achieving the same goal. Lastly, we'll be looking at seeing how best we can be able to track the progress in terms of the maturity of interoperability going forward. And the purpose of this adoption is to work with global best practices, such as the Measure Evaluation Health Information System Interoperability Maturity Toolkit, for that progressive monitoring and evaluation of the Kenya Ministry of Health interoperability journey. And as we implement it over time, just to ensure that we stay on course, and also we stay guided by the principles that we have put across. Right. So I hope I've been brief enough, but towards the end, Dr. Snell will guide us through how the hard copy will be shared later, so that we can have more details on the framework apart from this short presentation. Back to you, Karen.
Thank you. Thank you very much, Simba, for that presentation. I know the questions are coming fast and furious, and we want to have time to respond to the questions, but also get feedback from, again, Dr. Sitine and George from the National AIDS Control Council. But before we get to that, I'd like to invite Gitahi. Gitahi has been working with us to support Ministry of Health, National AIDS Control Council, and NASCOP, and I see Faith Ngari has joined us from NASCOP. And Gitahi has been supporting to just strengthen the dashboards on HIV and AIDS, so that you know, the data can sort of speak to one another more. And he has some lessons definitely from that experience. So Gitahi, do you want to take us through your work maybe for the next 10 minutes before we open up for Q&A?
Yes, Karen, can you hear me?
Yes, loud and clear.
Okay, and you can see my screen, right?
Yes.
Okay, great. So my name is Gitahi. As Karen has said, working with GPSDD on identifying opportunities for greater interoperability with respect to a number of different systems. We were particularly looking at the District Health Information System, DHIS2, the EID-VL system, as well as the transactional systems that receive data from the field directly, and then the repository systems that aggregate data from various sources, including these two. Particularly, we were looking at the situation room, domiciled at the National AIDS Control Council. We were also looking at the KHRO, the UHC dashboard. So I'm going to take you through our findings, reviewing these systems in terms of, as I said, identifying opportunities for enhanced interoperability, as well as some of the recommendations that we have come up with. We have submitted more detailed reports to GPSDD, so I'm just going to be highlighting the key findings and recommendations during this presentation. So these are some of the things that we found. The first one being that there is a lot of data that is being collected through these systems, but there is not enough analysis to support data use, which obviously means there is a gap in terms of being able to turn the data that we are collecting into data that can support evidence-based decision making. Another recurrent theme that kept coming up is there is a lack of documentation, both in terms of technical documentation for, like specifications for the requirements, design documents, developer manuals, but also user guides for the users who would actually use those systems. Yet another gap was missing and sometimes inaccurate data. This again was reported consistently, especially by the systems that, or by the people who run the systems that receive data from DHIS and from the VL. There were cases of duplicates occasioned by reporting on multiple form versions. So, a form gets upgraded and the facility continues to use both. So the same data is submitted more than once. There were challenges around incompatible disaggregations. So for example, for a given indicator, it used to be disaggregated as 0 to 7 years. Now it's 0 to 9 years. And when you want to compare that across the years using one version of the disaggregation with a year using a different version of the disaggregation, you find that you're not able to make those comparisons directly. We found that was a result to some degree of weak coordination between technical partners who develop the systems and the end users, in this case, strategic informatics and monitoring and evaluation people. And what this means is that requests for changes will be made, for example, on the DHIS. So can we have a form that looks like this to capture these additional variables? Can we disaggregate a particular indicator in these different age disaggregations? And the technical people will sometimes just go ahead and implement those requests, but we found that there needs to be a more detailed conversation about what the implications are, because then there is a tendency for it to appear like the requirements have been taken into account, but then later on, as I said, those kinds of comparisons are impossible to make, and then you cannot solve one problem by creating another one. We found some cases of lack of support and maintenance for systems. A good example, I think, is the ART dashboard, which was set up to help visualize the 90 targets by drawing data from the DHIS and from the EID viral load system, as well as population estimates from NAC. A system like that was only around for a short amount of time, and then as soon as the partner that was supporting the system was no longer supporting it, the system is currently not online anymore. This is also obviously contributed to by the point I made earlier, which is lack of documentation, meaning that it becomes difficult to inherit that system and continue to support it if you don't know how it was set up and where the different artifacts are located. Ad hoc interoperability has come up in both Daktari's and Solomon Simba's presentations, where systems have got their own ad hoc implementation of interoperability. That means common interoperability tasks like filtering and transformation and security and logging and so on are all being implemented independently at the different systems, even when interoperability actually works. So for example, between the DHIS and the situation room, or the LMIS and the situation room. That means that common interoperability challenges are getting solved repeatedly, which is not a very good use of resources. And down at the recommendations that we mentioned, one of the ways we think that issue can be addressed. Good. So in terms of recommendations, we found that it's going to be very important to prioritize documentation and make it an integral part of system development. I think the tendency is for people to think, okay, let's develop the system because that's what we need to do. Let's see it working, and then we are going to do documentation later. But our experience reviewing those 5 systems has been that system developers generally do not later on get to preparing the requisite documentation. And therefore, the recommendation is for documentation to be an integral part of the system development process, and to make sure that the requirements are documented, the system design is documented, API information about the available API endpoints is published, so that developers in future who want to integrate with your system have got something to go on. We also found that there is need to strengthen the transactional systems, which means that as much as we have KHRO to aggregate data from different sources for analysis and visualization, as much as we have the UHC dashboard, there's a lot of value in making sure that the systems that feed data into these repositories or into these visualization systems are contributing good quality data, because the analysis we get and the information we have for decision making is as good as the source. Also need to promote closer coordination between technical teams, in this case system developers and end users, to make sure that requirements are not only accommodated, but that we are also taking into account any implications on the flexibility for data analysis down the line. Sustainability planning, essentially planning to have, and I think Dr. Sitinai spoke to this in the beginning, having a sustainability plan from the get-go to make sure that systems are supported beyond the initial investment. So we have less of these situations where a system is developed and it is demoed and it is piloted. But if you look for it 2 or 3 years from now, then the system is different, which kind of beats the point that you are, the need that you are trying to address in the first place. Interoperability backbone, or interoperability layer, as it was called in the previous presentation. This speaks to solving the core problems of interoperability in a centralized manner, so that every integration opportunity, or every team that wants to integrate any two systems does not have to reinvent the wheel every time. So as I said, issues to do with filtering of data, transformation of data, securing data in transit, logging events, queuing, load balancing, and so on. All of those issues can be accommodated within one kind of interoperability backbone. And there are many solutions that can provide those kinds of, that kind of functionality, such as the interoperability layer, I believe developed by Palladium, Math Connect, OpenHIE, and so on. Now, as part of this work also, we are looking to, as Karen said, to enhance some of the dashboards available for the HIV program. In particular, we are currently working with the Health IT team, NASCOP and NAC, to load some population estimates into DHIS2, because that forms the denominator for the first 90. Reintegrating DHIS2 with the EID-VL system. That integration had been done earlier in 2017, but on reviewing it during this work, we found that it has since stopped working, and that there is need for improvement to make sure that it works on a more seamless, in a more seamless way going into the future. So that's also part of the work that we are doing. And then once we have all that data in both the DHIS and the situation room, implementing the necessary visualizations to track the 90, 90, 90, or 95, 95, 95, as I have been told recently, targets on those platforms. Yeah, so I think that marks the end of my presentation. Over to you, Karen, again.
Thank you so much, Gitahi, for that. And as you said, there's just some work in progress, almost finalizing on the visualizations. I'd like now to invite George. George Onyango is the technical person at the National AIDS Control Council, and we've been working with him on some of the challenges they've been facing on data and strengthening their data system. So I'll invite you, George, to give your remarks, and then I'll pass back to Daktari, and then we'll open up for Q&A. I know we have about 30 minutes to the end of the webinar, so I want to just give this the Q&A enough time for people to get feedback. So George, over to you.
Internet. Okay, hi, can you hear me?
Yes, George, we can hear you.
Okay, good. Good morning, all. Most, if not everything I was going to talk about, Gitahi Nganga has spoken about very eloquently. The number one challenge we've been having in implementation of the situation room was one, it seems like our data agreements were not that robust. So you will find where you have spoken to for example, DHIS, HIS team, KEMSA, LMIS team, and NASCOP VL, whatever it is we had agreed was we'll simply come in, extract, transform, and load data into the situation. Now, there is a challenge when it comes to that, because when they make any changes on the source system, our APIs will then bring us errors and nulls. And because the situation room is very high-end, top level, it does not necessarily do any aggregation of data. It simply brings in data into a data warehouse where we now do our own cleaning at the transform and load. So what has been happening is every time when we would present data, one of the issues we'd have is duplicated data, because some forms were changed at some point by the SI team. So some facilities are keying in both forms. Some facilities are keying in the old form. Some facilities are keying in the new form. So when you come to now finally do analytics and aggregation and presentation, you find the data owners, for example, counties are rejecting that data. Because when they go back into the source system, for example, Homa Bay is going to look at form, say, 711. Kisumu is going to look at form 730. What we are presenting is a summation of both, of 711 and 730. So in some of them, there will be no data. In some of them, there'll be duplicate data. That for us has been one very, very, very big challenge. Another challenge we've faced is, for example, HIV has changed how they do their age disaggregation. Initially, we had 0 to 9. Now here we start from 1 to 9. We had 10 to 24. Now we have 10 to 14, 15 to 19, then 20 to 24. So those bring quite a bit of challenges, especially when you're going to do analytics over a period of time. Because when the form changes, then you're going to get quite a bit of nulls coming in. So those some of the highlights of the issues we've been facing. And for us, the solution would be, one, to have guidelines on especially how the source systems are going to be collecting data, and two, have very robust data agreements, so that if any change is going to be made at the source, then those of us who are at the end of the whole data pipeline where we're doing the visualization and analytics also need to know of these changes beforehand, so we could start preparing for how we are going to deal with the analytics. But I think Gitahi has touched on everything that we've been going through, and I saw he highlighted them very well in his presentation. That is all I have for now. But what is key, and what is key for us, is synergy between the SI teams and the technical IT teams. We really must work together. Otherwise, there's always going to be a disconnect, because from the SI, they know what they want. But from IT, we know the limitations. For example, how it's going to affect analytics over a period of time. So if SI come in and they say we need to do this, there needs to be an agreement that if we change, the aggregations from this moment on, then when we're creating dashboards, then we're going to have more than one frame. So those are now part of my, sorry, I'm seeing there's quite a bit of questions. I will answer this after the panel. That for me is the only big issue I had to talk about, the connection between the SI and the IT technical. Thank you.
Thank you so much, George. You've kept it quite brief and to the point. I know the questions are coming fast and furious, if I'd use that word. And I just want to open this up as a sort of plenary Q&A. And I'll, of course, start with you, Dr. Sitine. I'd want you to give your feedback on, of course, the input from Solo, Simba, Gitahi, and George. But also, there are two questions that have come that I'd like you to respond to. One is from Rose Nzioka. I think Rose is with Palladium, and of course, she's grateful for your presentation, and this is a great vision. We know that reporting by private service providers is still low, but necessary to achieve the vision that you've outlined. Can you please speak to what the MOH is doing to put in place the laws and regulations needed to ensure that non-compliance is punishable by law and that there are carrots to promote compliance? So that's Rosa's question, and I'd like you to take that with a question from Francis and I think a couple of other participants who've asked how can they sort of work with the ministry? What sort of mechanism is there to allow other actors to work with you on supporting the visions that you've outlined? Over to you, Dr.
Thank you very much, Karen, and thank you very much, everybody, for your active participation. I'm seeing a lot of questions. I was trying to respond to them until I'm caught up, because the moment I respond to one, others come up. But I want to state that first, it is really great that there is a lot of interest in data, particularly not just by the people who are here, but even by the government. I think this is the time that the government is looking at the big data issues. And the issue surrounding big data is very important, because it is not just for decision making, but also for innovation, and maybe even coming up with the artificial intelligence. And this is where the government has missed all along. And the government is now particularly serious on making sure that this data is not only collected, but stored in a safe manner and used for what it is intended for. And that is why the government passed both the Health Act 2017 and the Data Protection Act 2019. And it will be good for us who are here to familiarize ourselves with what the requirements of these two acts of parliament. Because in the Health Act 2017, one of the things that is, as I said earlier, that is a requirement is that it is no longer a requirement to report, but it is mandatory. And failure to report means that there will be consequences, including being fined and also being jailed. That is embedded within the Health Act 2017. And that goes to the question that has been asked by Rose in relation to partners and especially the private sector who may not necessarily be reporting to us at the moment. But I want to open this and say that, to be very candid and say, we are not just facing challenges from that end in terms of data collection. Even within the public health facilities, we are not getting 100% reporting. And that is something that we want to put in place to make sure that the systems are able to cope with 100% reporting from the public sector. And then we move to the private sector so that we are moving to them when the platform is already in a stable situation. At the moment, a few of us who are in this meeting, and as I said, I'm going to be candid, know that we are having a few challenges with the DHIS, which we are also trying to address to overcome them. Some of the challenges are technical, some of them are non-technical. But the non-technical ones, we can handle them very fast, but the technical ones are the ones which we are trying to see how best to go over them. And to say it plainly again, is the fact that DHIS, where all our data is domiciled at the moment, captures service statistics, only service statistics. Where we are going, we want to move from service statistics to patient level data, where you can be able to see practically everything pertaining to that particular client. And I think the HIV world has made several steps towards actualizing that. The TB world has also made several steps towards actualizing that. The solution that the government is considering to roll out now is going to answer and to cure that challenge, because it is going to collect service level data. Having said that, I want to repeat the fact that the government is putting up a very modern storage facility for data. This facility, which will be at Afi House, is going to be so robust and hopefully scalable to capture all health data that is service level to provide for reports, but also that is patient level to provide quality care to patients. in a manner that it will enable referrals of patients from one facility to the next. It will enable telemedicine, because I have seen some questions which are coming around telemedicine. But these are progressive steps that the government is taking, and there is a lot of commitment from the government, including the highest political commitment. And for once, I would like us to trust that this process is going to take off, because the steps have already been made. And in the next few weeks, those of you who will be traveling, who will be able to walk to AFIA House, you will see action that is already taking place to try to create that type of a data center. That data center will be having a mirror within the government data centers. As I said earlier, there will be 58 in total, but we will be having a mirror at Konza City, because Konza City is real and connectivity is being done. I think it's almost towards the end, so that government departments can have their mirrors at that level. Having said that, the issues that have been raised also touch on the quality of the data. I've said that the reporting rate is not 100%, particularly for inpatient data, morbidity and mortality. Particularly mortality is not captured from the inpatient in Kenya, and a few facilities are reporting. Currently, about 60% of the public facilities are reporting on inpatient data, and we want to push that to the highest level that can be achieved. The accuracy of this data is, of course, one thing, because of the nature and the manner in which we collect this data. As long as the data is being collected from paper, transferred to another paper, and then tried to be digitized, there will be clerical errors. In addition, we do not have enough staff who collect the data at the service delivery point. More often, the people who fill those data recording tools and reporting tools are also service providers. And when you have a long queue outside there, you will not be concentrating on the data entries, but more on the patient. When we went out to look at the systems which are available, and I want to challenge the partners who are here, who have developed some form of electronic medical records. One key thing that came out and was said by one person is that they spend 30 minutes filling the tool, typing and doing the rest, and 5 minutes to see the patient. We want to transfer that backwards so that you spend more time with the patient so that you can be able to provide quality service and less time inputting data. That's where we are going. And to make the data useful, we are moving to the next level, which some of us have already alluded to, the data analytics. There is still a challenge in the data analytics because it is still paper-based, but also because we do not have the requisite resources to be able to develop adequate dashboards at different levels. We'd like to have a dashboard at the county level where the county executive, the governor, when he wakes up, he can see how many people died in his county that night or that day or something like that, how much he was able to collect. But this capacity is gradually being built. It is not going to happen overnight, but I know the partners who are here have assisted, and we can continue to do that. For example, the reference to the health observatory. Yes, this is a project that just ended towards the end I mean, in the last 3-4 months is when that project came to an end. But it has taken us a lot of time to reach where we've reached. And that has been possible because of support from partners, some of who are seated here. So these issues of data analytics are being looked at and they are being addressed gradually. And it is my hope that even as we go ahead, partners can now work with the ministry so that together we can pull in one direction. Issues surrounding inaccuracy of the data. I've talked about paper-based system, but I want to say something that has also come up in the recent past, that the tools which are in the field are old. Some of them are obsolete in the sense that we have revised the tools and we are now in the process of distributing the tools which have been revised. Our initial plan was that come 1st of July, we will have trained all the CHRIOs in the country to be able to use the new tools. Unfortunately, we are facing some challenges because the printing of the new tools is, can I say, 90% complete? 10% is not yet complete. And even this morning, I was following up this matter, and we have been informed that by the people who are doing this work that come next week, everything will have been delivered. So if you go to the field right now, you'll find 2 sets of data collection tools. But we need to drop the old data collection tool come 1st of July and transition to the new data collection tool. Again, we are facing challenges in terms of distribution of what we already have in our stores. We've reached out to partners who are able to do that. We've reached out to counties to be able to collect the data collection tools and transfer them to the counties. We are working now on a way in which we can be able to train the CHRIOs in the 2nd week of July, hopefully, so that we can all transition as a nation towards one set of tools to be used and out there. And even as we do that, we have to configure our DHIS to be able to capture now the data based on the revised tools. That one is already taking place. But I want to finally say, Chair, that the issues surrounding sustainability are important. And I think this has come out very well. I am aware that as we speak right now, the HIV world is already rolling out a program where they are migrating the data from the old systems that have been out there, the disparate systems that have been used in different facilities. They are now trying to pull that and migrate that data into a format that can be acceptable by Kenya EMR. But that is one step that we are moving ahead. And I have pleaded with them that even as they do that, let us work together in partnership with the government, because the government is also having its own plans on rolling out a digital solution. So if we do not consider issues of data migration at this time, if we do not consider the issues of interoperability, the future is going to be challenging, even if the government rolls out what it intends to roll out. I can see issues here which have been, somebody has asked about safety and security of the data. I want to assure you that the data will be extremely safe. So safe that you will not be able to penetrate first physically, and we are also putting in place the technical security measures to make sure that this data is properly stored and not somebody cannot penetrate to do what they may be, to mess up the data. The government is willing to partner with the private sector and any partner who is out here, and maybe we should have, as one of the outcome of this webinar, is that we should have a joint seminar, maybe just looking at health data, some sort of a conference, so that together we look at it in one direction and all partners understand what the government is doing. Partners also see the areas and the spaces that they can fit into, so that we pull in one direction as a country. And by doing that, we should be able to achieve the aspirations of the universal health coverage when we pull together in one direction. Thank you, Chair. I hope I've captured some of the issues that have been raised. Thank you. Over to you.
Thank you, Daktari. Yes, you've captured more than one, so that has been useful in sort of responding to more than one question. I just want to pass the next question to Solomon, and then I'll come to you, Gitahi, and then George. I think because of time, we'll just do one round, but then we'll respond to all the questions on email and give feedback to the participants. So, Solo, there's a question on the framework in terms of the source documents, which informed the interoperability framework. And there's also a question on the chat around what mechanisms have been recommended in terms of organizing institutions and organizations around interoperability. So do you want to touch on those two questions before I move to Gitahi?
Thank you, Karen. In terms of source documents, we were able to go through some of the assessments that were done before for HIS Health Information System readiness assessments. And apart from that, we also looked into the Data Protection Act that Dr. has mentioned, Health Act. We also did a good reference to the Kenya National Health Policy 2016-2030, the Kenya Health Enterprise Architecture, blueprint, which was done in 2016, and it talks about the holistic environment of the HIS ecosystem in this country. We have also other interoperability standard, which was also documented in 2015, which is the interoperability standard for HIS systems. EMR standard as well. We were able to reference that as well. So quite a number of other documents that we looked into to show that the interoperability framework is holistic and tries to pick recommendations from other existing and implemented policies. All right. In terms of the mechanisms that we proposed to have within the framework was to see how much possible we could relate the framework with the Ministry of Health Forum, which is the interagency coordinating committee, which is one of that multi-stakeholder body that brings together all the players within the health sector, and it is one of the highest decision-making forum for the national level, and also having that national level connect to the county level coordinating committees, right? So within the ICC, in short, there are 3 sub-technical working groups that the framework team and members will be working to ensure that they advance the agenda of the interoperability. So there's a health informatics, which is HI, and they'll be taking the lead in terms of the HIS system components, right? Policy adherence, and even compliance in terms of e-health certification, and even setting up some procedures and guidelines to support partners when it comes to designing systems, and when it comes to picking up some of the standard guidelines for system interoperability. We have a health matrix TWG, which would be taking lead looking at the health indicators, tools. I've seen people mention about tools, review, and some of those indicators and data elements that end up into a system that the team will be taking lead on that area. And lastly, the research and innovation, because research and innovation is one of those elements that were added into the health sector. And we like to see it's supposed to come up with research agendas and even innovations geared in the lines of interoperability. Back to you, Karen.
Thanks so much, Solo. So I'll come to you, Gitahi, and then to you, George, and I'll take the question from Sarah Malaba, and she wants to just know how have we inbuilt change management to support transition, retiring of all forms, data points, challenges, and this was articulated by George. I think Gitahi, based on your experience, of course, supporting this project and other work, you'll want to respond to that, and then I'll come to you, George.
Yes, I think that question has got 2 answers, and I have seen some of them, at least one of them in the chat. And the first is it's easiest to manipulate data most flexibly when you have patient level data. Because if you have patient level data for 100 patients, it's very easy to tell for any given indicator how many of those are between 1 and 18 years old, 19 and 30 years old, and so on. As opposed to when you receive what Dr. Sitiene is referring to as service statistics. However, because we have not reached there yet, the second approach is to appreciate that there are many of these technical solutions involve compromises. And sometimes we forget and make the assumption that if we want the systems people to implement a particular requirement, then they just go ahead and implement it. And yes, they may go ahead and implement it, but that solution does not exist in a vacuum. A lot of the time, it comes at the cost of potentially creating a new problem. And I think George talked about this when he said that the change in data disaggregations, for example, is a common way that this manifests itself. Because if you are reporting, for example, the number of people who've tested positive for HIV and disaggregating that as 0 to 7, and then later on it is 0 to 9, there is no way of comparing the age category 0 to 9 across the years, because a number of years from the past are going to have quote unquote the wrong disaggregations. And I think once we appreciate that point, then it means we can put more forethought into the requirements that we come up with, and kind of try to think about arranging that in a way that can serve the program for much longer going into the future. And then secondly, we can also work on reducing the frequency of making changes that can potentially result in incompatibility between older and newer data sets. Yeah, so I think those are the two kind of different ways I think that issue could potentially be addressed.
Thanks, Gitahi. George, do you want to take the question again from Sarah in terms of please outline for us key components that need to be included to make strong data agreements and the compliance mechanisms?
One is a change management mechanism, where if a change is going to be made, it is good for both parties to have a look at the risks that are involved in making that change. Just like Gitahi just said, when we are now looking at analytics, what will be the repercussions if we change our age disaggregations when it comes to analytics over a period of time? And also, most important, it would be good if a change is going to be made, then we must first test and implement and see what it is we are going to achieve. Is it going to work for the program? Is it going to work for the analytics? Because in many cases, when the changes are made, they're changed by the program manager, because the program manager now has new guidelines which come from either WHO or Ministry of Health, and they need to adhere to those guidelines. But now on our side as IT, we need to first understand what changes are going to be made and how it is going to affect our system, and we need to test and find how we are going to now deal with it. Like, for example, there is one of them where we have VMMC. VMMC does not come with a gender, because of course it's going to be male only. So when we are building our logic, when we are doing our extract, transform, and load, we actually had to build a logic within the platform in itself for it to drop this in the male gender in the system. So there's all those, especially change management, where we must work together before you actually go ahead and implement the change. We need to be ready on our side, because what has been lacking is changes are being made at the source system, because they understand how their system works, but they do not look at how ours works. So when a change is made, and in many cases, actually in all cases, by the time the situation room was going to run the ETL, the extract, transform, and load, we got errors. And we only found out changes were made once we spoke to HIS, and then they say to you, well, we've made some changes, this is the new API. So in the data agreement, a change management framework is important.
Thanks, George, for that. I think you've sort of parted with the change management framework as important. I wish I had more time to run this webinar. I think it's been really interesting and fast-paced, and the comments have come in, like I mentioned, fast and furious, and participants have also been very active. I think I'll just close with Dr. Kimanga's comment on a great meeting and great discussions, and sharing sentiments that we have enough frameworks, documents, policies, and guidelines in the country, and the challenge really is on the implementation. And as we move towards closing this webinar, I'd like my speakers to just reflect on these thoughts by Dr. Kimanga on how do we move from documents and policies to actually implementation and next steps. So for the closing remarks, I'll just want to invite Gitahi to give his remarks, and then George, and then Dr. Sitiene, and then we'll close with Davis. So I kindly request that maybe for the next 5 minutes or so before we end this webinar, that you bear with me as we give the closing remarks. So over to you, Gitahi.
Thank you, Karen. I think my closing remarks follow from the recommendations that I presented a little earlier. And also part of what I think is Dr. Kimanga's comment speaks to, which is that we don't have a shortage of information systems and platforms and documents talking about how we want to integrate all of these things. I think the most important thing now going forward is to move more towards implementation, to actualize these very good dreams we have about bringing data together. And there is both a technical component to that effort, but also a very big organizational component where we make sure that partners are talking to one another, stakeholders are talking to one another, but also the decisions that we are taking are getting documented so that innovation does not get stifled by the fact that anybody, any new person, any new entrant into the space has to begin their work from scratch every time. That's the main one for me. Thanks.
Thanks. George, please come in with your closing remarks and of course, you're stating your key takeaway from this work.
We are at the right time, all of us, because we understand the challenges that we are facing. Just like Gitahi said, there's no shortage of health information systems. Kenya is in a very good place. There's innovations coming up every day, and the innovations are brilliant. What we need to do is bring this together so that those who are making decisions get accurate and timely data. Because in everything that we do, there is a life we are going to save. That is what I say to myself every morning. In everything that I do, there is a life that I need to save. And for me to do that, I need to give technology that gives direct, correct, and accurate data on time. So for me, what I take away from this, Dr. Sitine has a brilliant, brilliant plan. I've looked at the whole diagram of the data flow. We should all strive to achieve this. And I know we will be able to save a life. Thank you.
Thank you, George. Dr. Sitine, I'd want to just pass this now to you to give your parting shot and of course, your key takeaways from this work.
Thank you very much, Karen, again. Thank you very much, everybody, for participating. For me, as I said, this is the beginning of everything, and it's not the end of anything. So looking forward, there is a bright future. If we continue working together in partnership with the government, I see Kenya being transformed in the next few months to a level where we shall be able to collect data that is required for every patient anytime. In fact, what I could quickly add to that is that I forgot to mention that in the architecture that I shared, we also have a patient and community portal, a system where patients can even be able to track some information about themselves, whether it is blood sugar or blood pressure or whatever. They should be able to see it. And also for the community. I see a bright future, good people. There is nothing that can stop us except ourselves. This is time now to act and to move. And together we can do it. And to me, we need to come back again to have a conference where it is possible on health data and how health is being managed in this country. If we plan to have, even if it is a virtual conference for half a day like we've done today, I'm sure we can get various presentations and very important lessons that have been learned by partners in the field. But I want to finally say that this country is great and it's bigger than each and every one of us. Whatever we do, we contribute in one way or another towards a bigger picture. Let us each do our best wherever we are, and to always remember that when we do this, we are doing it for ourselves and we are doing it for this country. And if we do that very well, I'm sure nothing will stop us from making Kenya a digitized society. Thank you very much. Over to you.
Thank you, Dr. I just want to pass the baton now to Davis to help us close this webinar. I know it's been interesting and we've learned a lot. And of course, we've accepted the challenge from Dr. Sitine on hosting another virtual or physical event whichever comes first in terms of talking about health data in Kenya. So Davis, please, over to you.
No, thank you so much, Karen, and a huge congratulations to you, Dr. Sitinei, of course, and all the other partners who've been involved in making this possible. Hugely exciting webinar. I've learned a lot, and of course, like they say, you know, we'll really celebrate when the rubber actually meets the road. So this is a great framework, but the challenge is, you know, how do we move from this to practice? And of course, there could be opportunities to start small and of course, test in certain areas when it comes to either the technology itself. And of course, the most important thing about this is human interoperability. So we invite all partners who are on this call and many others who are interested to really share with us ideas on how we can work together. And of course, the idea would be for us to really aggregate this so that when we meet next time, as Dr. Sitinei is proposing, we'll be talking about very practical steps on moving this forward. So thank you so much for everyone who found time to join us this morning. And we definitely look forward to continued collaboration and working with you. It's definitely not the end. Thank you.
Great, thanks everyone. As you'll see in front of your screen, I've launched a poll just to get feedback on your experience in this. I'd appreciate if you just take a minute to fill that form. But otherwise, thank you so much for taking time to join us. We appreciate, we'll be responding to all the questions that came through via email. We'll also be sharing the recording on YouTube and the documents that have been requested for the framework and also the digital survey that Dr. Sitinei talked about. So we'll share all that on email. If you have any further questions, please do not hesitate to reach out to me. I'd be more than happy to respond or to assist. With that, I wish to thank everyone for staying with us for 1.5 hours. I'm sure it has been intense and interesting, and I really appreciate your time. Till next time, and maybe in another webinar or in another meeting talking about health data, we'll see you again. Thank you, and have a nice rest of your day. Goodbye.